Dear students, we have few questions on WhatsApp to discuss. So the first question is asking something about the symptomatic irreversible pulpitis pain in which of the following sites most likely to radiate to the ear. So the now question is basically asking about the pain is radiating to the ear, and the options are maxillary premolar, maxillary molar, mandibular premolar and mandibular molar. So now the probability of pain radiating to the ear when compared to maxilla, mandible will have the high chances of radiating pain to the ear. So when the options were there like mandibular, premolar and molar, the posterior most tooth should be chosen as a correct option, that is the molars. So in molars also, if there is a third molar in the option, the most probable tooth to radiate the pain to the ear will be the pain associated with the last tooth in the mandible. So it's the mandibular molar in this particular question is the right option. Next question is, which of the following statements regarding the treatment of tooth manifesting the sinus tract is true? Now the patient have come with you with the formation of a sinus tract. That means the entire tooth structure pulp is completely destroyed, and now there is a sinus tract which is formed by the tooth around the tooth structure in order to drain its contents. So there is there is so much of pressure inside the tooth that has been built in. Now the tooth wants to relieve that pressure out completely, so it finds its way to a sinus tract, so that in abscess conditions there is a sinus tract which is formed and a draining discharge of pus from that tract. Now how do we address such cases is that first we have to check for the periodontal attachment. If at all, because of the huge abscess that is formed, if the tooth is mobile completely, we cannot save the tooth. Mobile tooth with abscess cannot be saved. But here the question is not mentioning about the periodontal condition at all. The question says that there is only sinus tract. What we can do to our best to save the tooth is to do the root canal therapy, that is endodontic therapy, and then we need to actually wait for 2 to 4 weeks so the after the root canal therapy, so that it will heal by itself. In all the options, and there is no absolute need of antibiotics at this particular point of time. So option A, treat with the conventional endodontic therapy, antibiotics not needed. Option B. Option C, sinus tract heal in 2 to 4 weeks after your conventional RCT. If the sinus tract persists after root canal therapy, perform the root and surgery with root and filling. Yes, all the above statements are true, dear students. So if at all the sinus tract is not recovered or it still persists, then we have to do the root and surgery and retrograde filling to save the tooth. So all these are correct. All the above is the correct answer to be chosen. Next question, a classic teardrop shaped apical lesion on the radiograph indicate the vertical root fracture. The prognosis of vertical root fracture is hopeless and the tooth should be extracted. When it comes to the point of vertical root fractures, so Ellis class 1, class 2, class 3 up to Ellis class 8, there are different types of managements in these fractures which we will discuss in the upcoming sessions, but in this particular point it's a vertical fracture. In whatsoever case, we cannot save a tooth which is involved in the vertical fracture. The only line of treatment for vertical fractures is to extract the tooth. So the first statement is talking about the radiographic appearance. Yes, classic teardrop shaped radiographic appearance is particular for the vertical root fractures. So statement A is correct, and extraction is also the statement 2, that is also correct. So both the statements are true in this particular question. Moving on to the next question, it's a big clinical question. A patient presents with the chief complaint of swelling in the mandibular left quadrant that started 2 days ago and developed quickly. It developed quickly, that means it's an acute condition and there is a swelling. So these are the 2 points that you have to keep in your mind in that particular first line. It is acute condition and it has there is a swelling. The patient has mild fever, so that is infectious, And the clinical examination revealed there is a fluctuant swelling. What is the meaning of fluctuant, dear students? It is fluid filled. So fluctuant swelling in the buccal vestibule. So what might be the diagnosis for this? There is a fluctuant swelling and it is suddenly increasing and there is infection. It cannot be a symptomatic irreversible pulpitis or periodontitis, apical periodontitis. No. It is acute apical abscess. I said you it is grown suddenly, so it is acute. And there is a fluctuant mass of swelling in the vestibule. So it is abscess. It's acute apical abscess and this is how we have to diagnose the case. Now coming to the pathognomic symptoms of symptomatic apical periodontitis. Pathognomic symptoms of apical periodontitis is tenderness on vertical percussion. So if there is tenderness on vertical percussion, it is apical periodontitis. That's it. Okay. If there is tenderness on horizontal percussion, it is a periodontal condition, not an endodontic problem. Okay, it's not a sequela of pulpitis, it's a sequela of periodontal problem. If it is tenderness on horizontal percussion. If it is tenderness on vertical percussion, it is a pathognomic feature for apical periodontitis, which is a sequela of your pulpitis infection. The differentiating test between an endodontic abscess and the periodontal abscess. The first test is option A, vitality, pulp vitality, probing depth, percussion sensitivity, degree of mobility. See, whether to differentiate between an endodontic abscess and a periodontal abscess, the probing depth will tell you whether it's a periodontal problem or not. It cannot tell you an endodontic problem is involved or not. So rule out probing depth. Percussion sensitivity, as I have said, vertical percussion, it is endodontics. Horizontal percussion, it is periodontic problem. So that can also be cannot be a differentiating, particularly differentiating feature, because both for endodontic problem and periodontal problem there is sensitivity on percussion. Degree of mobility, not that an endodontic problem is leading to the mobility or a periodontal problem is the cause for might be the we can rule out that there is any periodontal lesion is involved, so the mobility is coming up. The only test that can differentiate between your periodontal and endodontic abscess will be your pulp vitality test. So this pulp vitality test will tell you if the tooth is vital and there is an abscess, then it is undoubtedly it's a periodontal abscess. If tooth is non-vital in pulp vitality, it is an endodontic abscess. So pulp vitality is a differentiating baseline test that we can perform. Percussion sensitivity, the tooth will be sensitive for periodontal abscess also and endodontic abscess also. The tooth will be sensitive. In a periodontal, apical periodontal case, tooth is tender on vertical percussion, and chronic periodontitis, horizontal percussion, the tooth is tender. In a tooth with primary periodontal lesion with secondary endodontic involvement, proceed first with. So whether it is a true endoperio lesion or not, you have to first do it the endodontic therapy, see the tooth is strong enough to survive, and then think of the periodontal attachments. So even though it is a true endoperio lesion, what we have to do is to first do the endodontic therapy, then proceed with the periodontic therapy. So it should be addressed first with non-surgical endodontic treatment, option B. And there is again a clinical scenario. A patient calls late Saturday night because of severe throbbing pain in the mandibular premolar, which is aggravated by heat, biting, touching. What is the procedure that is recommended? So there are several options given. It is considered basically as an endodontic emergency. Call the patient to your office and start the endodontic treatment. That is the only option that we can choose. We cannot ask the patient to take an analgesic or refer to an oral surgery. All these are not necessary. All that you have to do is to rule out that that is a symptomatic irreversible pulpitis. That is the case what you are looking up to in that particular question. So it is symptomatic irreversible pulpitis where you have to perform the endodontic therapy and you need to address the patient in such a way that you need not to go for any extractions as such or analgesics. No, you have to perform the endodontic therapy. Now, in a patient emergency, symptomatic irreversible pulpitis and symptomatic apical periodontitis, which of the following is best treatment protocol? See, when there is apical periodontitis with symptomatic irreversible pulpitis, it's an endodontic case. We have to go with an anesthesia and do pulpectomy. Okay, it's not an extraction case or incision drainage case. We cannot do incision drainage because the question is not asking absolutely about the abscess. It's asking about apical periodontitis, where we have to do pulp extirpation and it is pulpectomy, which is followed by anesthesia. Which is the best timing for performing incision and drainage at the area of infection? So the options were when the swelling is hard and diffuse, when the area is more painful, when the area is large, when the swelling is localized and fluctuant. See, when we have to do incision and drainage, first point you have to remember is it should be a fluid filled cavity. It shouldn't be hard. Any hard swellings cannot be treated with incision and drainage. Only fluid filled cavities such as your abscess and fluctuant masses can be treated with your incision and drainage. So it should be a fluctuant mass and it should be localized, as it's there in the option D. It should be localized. It should not be a widespread or a diffuse swelling that you cannot address with incision and drainage. We have to perform incision and drainage to a localized fluctuant mass of swelling. That's it. It should not be a hard mass or a hard swelling. We cannot perform incision and drainage. Where we have to give the incision for the drainage is that the most determinant part of the swelling or the most prominent part of the swelling where the entire fluid concentration's weight is concentrated. That is the point, peak point, where you have to give the incision and make the contents drain and keep a drain there and let the contents drain out of them for 2 to 3 days and then remove the drain and close it. So this is what it closes by itself. This is how we do an incision and drainage. These are the few MCQs that we would discuss in the WhatsApp.